Okay, so now we're going to talk about adult bradycardia with a pulse. So once again, this patient is going to present much more stable than the past patient we talked about with pulseless VT or VFib. So first you want to make sure that the patient is bradycardic. So for example, we'll get an EKG, and in this case, this is an example of a patient with bradycardia. So we'll calculate the rate just to make sure. So once again, I use the big box rule from peak to peak, QRS to QRS, and we'll go 300, 150, 100, 75, 60, 50, 40. So the rate is about 40 beats per minute, and bradycardia is defined as being less than 50 beats per minute. So this indeed does fit that criteria. So the next step would be to maintain patent airways, give the patient oxygen if they're hypoxemic, apply a cardiac monitor to identify the rhythm and monitor blood pressure and oximetry. And also we put on a 12-lead EKG if available, but making sure not to delay therapy, because the main goal is to treat the patient and get them back to being stable, rather than wasting time to apply an EKG if it's not fully necessary. So then you want to see if there's persistent bradyarrhythmia causing either 5 things: hypotension, signs of shock, acute altered mental status, acute heart failure, or ischemic chest discomfort. So if the answer is no, none of that, then you just observe and monitor the patient to see if they get better. However, if they are having either hypotension, shock, acute heart failure, ischemic chest discomfort, or altered mental status, so basically they do not seem stable, you would then start with atropine. IV atropine, first dose of 0.5 milligram bolus, and then you repeat this every 3 to 5 minutes. The maximum you give is 3 milligrams. Other options are dopamine or epinephrine, both IV, and both are 2 to 10 micrograms per kilogram per minute.